came back to take us through management of psychotic disorders. And he finished the day by discussing. You can't hear? Ah, okay. Hello? Good. So what I said was that yesterday we went through, an overview of psychotic disorders using schizophrenia as a model. And then Dr. Abuchi took us through the antipsychotic medications and highlighted, some of the drug-related issues associated with the use of the antipsychotics in the management of mental disorders. And then Dr. Doni came back, reinforced Dr. Abuchi's presentation, and also took us through the actual management of psychotic disorders. And then he ended the day by taking us through mood disorders, where we discussed depression and mania. So this morning, Dr. Abuchi will take us through, the psychopharmacology of mood disorders. For those of you who just joined us, who are not here, Dr. Abuchi is a senior lecturer, and he has worked very hard to major in neuropharmacology. He has a lot of collaborations with a lot of practitioners, on the field in Ghana and abroad. And I think yesterday, those of you who were here attested to the good work, that he did. So this morning, Doc, over to you.
Okay, good morning. So, am I audible? It's as if hello? 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 Okay. All right, thank you very much. So, we have a lot of interesting things again to talk about this morning. And so we want to look at drugs that are available for the management of mood disorders. Okay. So it's going to be in two parts. The first part will deal with the antidepressants. And then the second part would look at the drugs for bipolar disorder. The drugs used for bipolar are different from those for the depression. And even depression as part of bipolar responds differently to unipolar depression on its own. So the drugs are different. So we are going to look at the drugs and then their pharmacology. Okay. So this is clinical psychopharmacology of mood disorders. So we always have to begin by looking at the pathophysiology. Once we understand that, then the mechanism of action of the drugs and the adverse effects will be easier to understand. You might be disappointed to know that we do not completely understand the pathophysiology of depression. In fact, the West is bipolar. Very little is known about the pathophysiology. The drugs used were discovered, most of them were discovered by chance. So there was no deliberate design of any drug based on any mechanism, okay? As for antidepressants, there are, but the initial ones were all discovered by chance. So the pathophysiology, currently we believe that there are several mechanisms that are interacting together. Initially, there was the belief that it was due to a reduction in certain neurotransmitters, what are called monoamines, okay? But that is not entirely the story. The involvement of monoamines in the pathophysiology of depression is just part of the picture, okay? Even though that is the most popular explanation for what is happening in depression, there are other equally important mechanisms. So now, instead of just looking at the pathophysiology as being due to an imbalance in monoamines, we want to look at the a complete picture where the condition is due to a number of interacting systems working together. Okay. So I just highlight a few of these. And the difficulty in psychiatry in general is that the diagnosis of psychiatric conditions is made on the basis of symptoms. Okay, that is the greatest challenge. So you look at somebody, look at the symptoms, and based on a diagnostic criteria, DSM or ICD, then you decide that this person has depression or this person has psychosis. The underlying pathophysiology might be different. The fact that we are all showing similar symptoms doesn't necessarily mean that our problem is caused by the same aberrations in the brain. Okay, so it creates a complication. So you have a theory, a hypothesis for the way depression works, and you find that it doesn't apply to everybody. And that is why the lot of the drugs we use, which were based on the monoamine hypothesis, do not work for everybody, because probably what is creating the depression might be different in them. Okay, so theirs might be related to maybe something slightly different that may have a link to the monoamine system, though, but it's slightly different from what you are expecting. So because most of the drugs are based on the monoamine hypothesis, I'll spend some time on that one. But before we get there, let me say something briefly about some of the other competing explanations of why depression occurs. In fact, the one that is so popular, close to the monoamine hypothesis, is what is called the neurotrophic hypothesis. The understanding here is that what is causing depression is actually the loss of neurons in parts of the brain that control our mood. And the loss of neurons in these areas is also due to the reduction in the amount of chemical substances that keep these neurons alive, what are called neurotrophic factors. So the neurotrophic hypothesis says that depression is occurring because of lack of support for neurons that are regulating our mood. So they begin to die off, they lose control over the mood, and so the person then goes into depression. So if you want to treat depression, then get drugs that can increase some of these neurotrophic factors to promote the growth of neurons or synapse formation, link formation between neurons that control the mood, and that is going to improve the symptoms of depression. The interesting thing is that there is evidence that antidepressants do exactly this in the long term. Even after affecting monoamines, they end up also supporting the neurons to grow back, and then the symptoms of the depression resolves. So they are kind of interlinked. Then the next point is the involvement of the endocrine system. They have found that in some depressed patients, in a fraction of depressed patients, there is a dysfunction in the hypothalamic pituitary adrenal axis function, HPA axis function. You pick some of the patients and their plasma cortisol level is so high, and it does not respond to the popular dexamethasone suppression tests, which means that their HPA axis is malfunctioning. And one thing that is known about high levels of cortisol in the lab, if you take neuron cells, you add cortisol to them, is that it kills them. So there is a school of thought that the high levels of cortisol in these people might be damaging the neurons that are supposed to regulate their mood. That is why they are in that situation. And this hypothesis is also attractive because we now know that stress is very important in the development of depression. Most of the time, if you trace a depressed patient's history, you find that the person would have experienced some significant stress, okay? Life adversity or something significant. So what is the link? The stress, continuous stress in the person leads to the dysfunction in the HPA axis. which is going to affect the neurons that control the mood, and so this happens. Then cytokines should also have a role. Why? Because for those of you who have followed hepatitis B patients on interferon, you find that one of the adverse effects with time is that their mood changes. They become depressed. Some way, somehow, some of the cytokines, when they are elevated in plasma, can also lead to depressive symptoms. Okay. And then finally, the role of glutamate again. Somebody discovered by chance that sub-anesthetic doses of ketamine, the general anesthetic ketamine, which is an antagonist of one of the glutamate receptors, the NMDA receptor. Somebody discovered by chance that when you give an infusion of sub-anesthetic doses of ketamine to a depressed patient, within a few hours, the symptoms of the depression goes down. It vanishes. Just that the effect doesn't last. After a few days, it returns. When you take our current antidepressants, you need a minimum of 2 to 4 weeks to see a response. The drugs don't work immediately. So it appears that glutamate probably has a much better role in depression than the monoamines that we have been chasing. You see, so there is now an attempt there to understand that mechanism and see if we can make drugs that are rapidly acting antidepressants that you can take within a few hours and you are okay. You don't have to wait for weeks to see a response. Okay. So what point am I making? There are several problems in depression. We have been obsessed with one theory, but there are other important things that are involved in the pathophysiology. So we will do the usual thing by now focusing on the monoamine one, the one that drugs affect most, and then see the mechanism. So the monoamine hypothesis was the very first explanation put forward for what is happening in depression, what accounts for the symptoms. And the discovery of this has also been instrumental in developing the theories about how depression occurs in the brain. So just through pharmacological observations, two scientists, there is one guy called Schildkraut in the US, another guy called Ashcroft in UK. They were observing things independently in their labs, and they found that it appears that drugs that increase the concentrations of monoamines. When we say monoamines, we are referring to neurotransmitters, which include serotonin, noradrenaline, dopamine, and a few others. They have one amine group in their structure. Okay, so the critical ones in depression are serotonin and noradrenaline. But at the beginning, dopamine was part of it. So they found that drugs that increase the concentrations of these substances are antidepressants. And then drugs that reduce the concentrations of monoamines in the brain are also, they also induce depression, okay? So the same Resipin drug we mentioned yesterday is featuring here too. So one of the adverse effects of using Resipin, which reduces monoamine levels in the brain, is depression. And then antidepressants work by increasing the levels of monoamines. Okay. So based on these observations, these guys came up with the monoamine hypothesis that the symptoms of depression are due to depleted concentrations of monoamines, in particular serotonin, noradrenaline, and dopamine. Now we know dopamine is not so important. So the key ones are serotonin and noradrenaline. But the theory doesn't explain everything about depression very well. It has limitations. Okay, that is why the other ones I mentioned are very important. Some of the limitations are this: that when you take an antidepressant, you swallow a tablet of antidepressant, within a few hours, you find that your serotonin or your noradrenaline levels are high. within a few hours. But your depression symptoms do not go until a minimum of 2 weeks, 2 to 4. It can even go as much as 6 or 8 weeks before you see a response in the patient. So what is happening? If the depression is just due to depleted levels of these substances, why is it that when you take a drug that increases these substances, you don't see an improvement immediately? It means that there is something beyond the increase in those substances that is causing the actual improvement, okay? And so the guy who brought the neurotrophic hypothesis says that it is his hypothesis that fills in that gap, because the growth of neurons takes time. So if the antidepressant increases the monoamine levels, then the monoamine effects will then be to produce more substances that will cause the neurons to grow back and form more connections in the areas that control your mood. Then you can recover. Okay? So that is the link between those two. The other challenge is that all antidepressants seem to have the same efficacy. It doesn't matter which one you choose. The effect that you get is very similar. So when clinicians are selecting antidepressants, most of the time they select based on the adverse effects than the efficacy, because the efficacies are similar. There is not much difference between them, okay? So this is also a challenge. How is it that antidepressants affecting several areas of the brain would have similar efficacies? It's difficult to explain. And then again, no one has been able to consistently establish that monoamine levels are really decreased in the brain. That has not been clearly established. You find in some people, you won't find in others. Okay? Right. Now, so I want to explain what the monoamine hypothesis is saying in a nutshell, and how the drugs fit in. What is the mechanism of the drugs? Okay? So I want you to watch this, and as you are watching, then I'm explaining. So let's enter the brain and see the interactions between the various neurons. So within the brain, you have an estimated 100 billion neurons interacting with each other. Each neuron interacts with, on average, about 7,000 other neurons around it. Okay? So if we focus on just one of that interacting with another one, okay, so this is one neuron interacting with another one. What we know from our basic physiology is that the neurons don't directly interact with each other. There is no physical contact. So the axon of one interacts with the other, but there is a gap. So in order for the stimulus to cross to the other neuron, the first neuron has to release a neurotransmitter substance, okay, that will cross over and then stimulate receptors that are here, and then that will generate another flow of impulse to the other neuron. Okay. So that is the illustration. So the excitation comes with the blue substance there is a neurotransmitter. So as it gets here, binds to receptors here, then there is the conduction of the impulse. So the monoamine theory is saying that for those who are depressed, then there are neurons, the neurons in the areas controlling the mood that release serotonin or noradrenaline. Those neurons are not able to release enough of those transmitters, okay? So the transmitter release here is not enough to cause activity in the other neuron, which is important for your mood regulation. So there is a depletion of the transmitters here, okay? Now, look at the mechanism of how the transmitter is released, it acts, and some of it is taken back by these yellow structures. So look at those yellow structures. You see, they take the transmitters back when they are released. Those yellow structures there are called transporters. Transporters. So when the neurotransmitter is released, it binds to the receptor. The transporters will take them back. Other than that, they would continue to stimulate the other neuron unnecessarily, and that will cause a disorder in the brain, okay? So the yellow structures, the transporters will take them back into where they came from, the presynaptic terminal. Now, so I want to ask you, if the problem in depression is because you have reduced amounts of the transmitters there, and you want to increase the concentrations of the transmitters at that place, what do you think, if you want to design a drug to do something, what do you think can be targeted? Looking at what you've described, anybody?
The transporter.
The transporter. We all agree?
Yes.
So the transporter. So once you block the transporter, whatever is released doesn't go back. It stays there. The next batch adds up to it. The next batch adds up. So eventually it accumulates. Okay, and then that is going to stimulate the subsequent neuron. You have more activity. So this is the mechanism of the drugs we call the monoamine uptake inhibitors. That is how they work. Okay. So, in the video, so the antidepressants in this video are the white balls. See, so once they block the transporter, whatever is released is not taken back. So the concentrations increase, okay? Good. So the same thing in the video is here, okay? Just that now I have a postsynaptic neuron. For the sake of illustration. You don't see the two interacting with one postsynaptic, but it's just for the sake of illustration. So this is for the noradrenergic side. No, this is for the serotonergic neuron interacting. This is for the adrenergic side interacting, okay? So the transmitter is released, it binds to receptors, and this is our transporter. So the transporter that takes up serotonin at its synapse is called the serotonin transporter, SERT, S-E-R-T. And then on the noradrenaline side, for neurons that really, yes.
Please, I have a question.
Okay.
I just want to know, in someone who is not depressed, does that mean there's a natural way of blocking the transporters? Because you're saying if the antidepressant goes in, it goes to block the transporters. So I just want to know, in someone who is not, depressed, what happens?
Yes, in someone who is not depressed, you don't need to block the transporters. That is not important for. In that person, the transmission is going normally. There is no challenge. So you don't want to increase anything there. But in the depressed person, we are saying that the levels are lower. So it's not able to stimulate the second neuron. So for that person, you want to produce more, get more there so that, it can flow. Okay. Right. So this is our transporter illustrated here. This is SERT. The one for noradrenaline at the noradrenergic side is NET, norepinephrine or noradrenaline transporter. So once you take your antidepressant, which works by uptake inhibition, it will block either this or that, okay? If your antidepressant only blocks SERT, then we call it a selective serotonin reuptake inhibitor because it's only targeting the serotonin side. So it's only serotonin levels that will increase, okay? If it's a norepinephrine uptake inhibitor, a drug like riboseti, for example, it's only going to target the net, the norepinephrine transport. It's only norepinephrine that will increase, okay? Right. Then you have some of the drugs that cannot differentiate between, they are not specific. They will block both, like tricyclic antidepressants or serotonin noradrenaline reuptake inhibitors, a drug like venlafaxine or duloxetine. Okay, they are going to affect the two. Okay, so that explains the mechanism of parts of the agent, in fact, a chunk of them. But we also have other drugs with other mechanisms. Okay,
Dr. Bochi.
Yes.
Don't assume that they know the names of these drugs.
Yeah, we shall come to that.
Exactly.
We shall come to that. So I'm just making some examples. We shall look at the drugs in details. Okay. So I'm giving an overview, explaining the mechanisms, so that when we move on, I mean, we don't have to explain mechanisms again. Okay.
Please, I have a question.
Okay.
Yeah, my question is about the blockage. Is this partial or permanent? Well, what happens if it is blocked and the amount that is of the transmitter that's being released becomes too much?
So is it partial or is it a permanent block?
Is it reversible?
Reversible,
yeah.
Yes, it is. It's a reversible block. In fact, the truth of the matter, the accurate mechanism is not that the drug would necessarily block the entrance, but most of them will attach to the transporter is a protein, so they will attach to it and the protein will refuse to open because they have attached, they have a way of preventing the transporter from opening, okay, in order to take. They don't actually block the entrance, okay, but this is just for you to get the concept, okay. So once they attach to it, they can leave, okay, but because the drug molecules are many, the effect is very significant. There are several drug molecules at the nerve end. So if this one binds and leaves, another molecule will come and bind. Are you getting the point? Okay, any other?
Yes, Dr. Abuchi.
Okay.
My name is Dennis.
Okay.
I wanted to ask if the blockade of the two,
Yes.
the set and the net, compared to the blockade of either,
Yeah.
which was going to be more effective. And then I got my answer from the fact that I said efficacy-wise, they are all
they are.
So will I assume that the one that will block both will produce more side effects?
Yes. The norepinephrine, the noradrenaline side especially, is a source of a lot of side effects. Of course, the serotonin side produces, but the introduction of the norepinephrine levels, when they increase, they create so many adverse effects in addition to that. If you just block the set alone, the side effects are minimal compared to if you block both. Okay, right.
To find out at the synaptic junction, when the neurotransmitters are released, do they have a period of time where the art and maybe the activities is downgraded, or what I want to really know is whether there is degradation of the neurotransmitters at that junction, and how long do they stay there?
How long do they stay? That would be very difficult for me to say. But, you know, as soon as the mechanisms are in continuous motion, as soon as the transmitter comes down, the transporter is also working concurrently. Do you understand? So as it comes down, it is those closer to the transporter will begin to be taken back. Those that are further away, they will be acting on the receptors. And then by the time those closer to the transporter are taken back, those closer to the receptors would have done their job. Then they are also taken back. So it's a fluid situation. I mean, there is no necessary delay where you say something should keep the drug there for some time or the transmitter there for some time before it is taken back. Okay. All right. So
Please, I have a question.
Yes.
Please, has it also been established that the receptors can also be defective or become insensitive? So you have enough neurotransmitters released, but the receptor reaction wouldn't take place.
Okay, yes, that is also a possibility. That can happen where the receptors are either fewer, they are down-regulated, they are fewer, they are not enough to conduct. That is a possibility. Okay, but even if the receptors are few, once you get a lot of the transmitter there, it doesn't matter whether they are few or not. The few receptors there, once they have a lot of transmitters, the stimulation will be higher and the problem will be solved. Are you following? So that can be part of the pathophysiology. Somebody's depression can occur because the receptors are fewer. Somebody's maybe because not enough transmitter is released. But whatever be the case, once the transmitter levels are increased, everyone should be fine. I hope that's okay.
Yeah, so we can make progress.
Yeah. Okay, so when the transmitters are taken back, in the absence of the transporter, the natural thing is that once the transmitter is released, for example, the serotonergic site is taken back by this transporter here. Now, when it comes up, two things can happen. It can be sent into another vesicle, another container there for it, which can be released, or there is an enzyme in there called monoamine oxidase. That is a natural enzyme that breaks down the transmitter. So two things can happen. It can be packaged, or that enzyme will break it down, reducing the amount in the presynaptic terminal. Are you following? So another strategy in increasing the concentrations of the transmitters is to inhibit that enzyme. Are you following? So that whatever is taken up, some will not be broken down, all will be packaged again and released. Okay? So that is the mechanism of another class of antidepressants called the monoamine oxidase inhibitors. Okay? Right. Now, that enzyme occurs in two forms. There is monoamine oxidase A, there is B. The one involved in depression is the A. So that is what is targeted. The B is important for dopamine metabolism in the brain. So in Parkinson's disease, where you have low levels of dopamine, then you can use the B inhibitor to increase dopamine to improve the symptoms in Parkinson's. So we all know selegiline, isn't it? Selegiline at low concentrations is selective for the type B. That is why we use it in Parkinson's, okay? Right. So those are the main mechanisms. There are drugs also that interact with some other receptors. There are receptors located here, the presynaptic terminal. They are not shown in this diagram. Their job is to regulate how much of the transmitter is released here. For the noradrenergic side, the receptor there is called alpha-2 receptor, okay? The target for the drug clonidine, or apraclonidine, or brominidine, and those drugs, okay? And then the one here is 5-HT1, okay? They are all there. Their job is that when the transmitter levels are too much, they will be activated and they will slow down the release of the transmitter. So they are working against increasing the levels here. Are you following? So some of the antidepressants will work by inhibiting those receptors at the top there to allow the transmitters to flow without any suppression. That is also part of the mechanism of some. Okay. So these are the main mechanisms of antidepressants. I hope everyone is fine. Okay, so we can move on. I have already...
Dr. Awochi, please,
yes.
Can you take that last bit again?
About the what we call presynaptic receptors.
Yes.
Okay.
Yes.
So they are located here. For the adrenergic side, you'll find a receptor here called the alpha-2 receptor. Its job is to monitor the synapse. If the noradrenaline level is too high, it will work to suppress the concentrations. Are you following? On the serotonergic side, the receptor is called 5-HT1, okay? and that would also be monitoring what is happening there, okay? Now, I didn't want to bring in this complication, but one of the reasons ascribed to why there is a delay when you take an antidepressant is that those receptors are aggressive at the beginning, trying to prevent your drug from increasing the levels of the transmitters. But as you keep taking the drug, they become desensitized. They become desensitized. They lose activity because of the excessive transmitter that is there. So it's from that point on that they allow the transmitters to flow freely, okay? It's part of the delay in why the drug doesn't work quickly enough, okay? Good. So these are the drug classes that we have. So monoamine uptake inhibitors, under that we have subgroups either based on their chemical structure or their mechanism. So you see the first group there, the tricyclic antidepressants. That group is a chemical class. All the drugs in there have tricyclic rings in their chemical structure, okay? Then the rest are based on the mechanism. Selective serotonin reuptake inhibitors, they only affect SET. Serotonin noradrenaline reuptake inhibitors, they affect both NET and SET, but they are not tricyclics in chemical structure. Are you following? Right. Then noradrenaline reuptake inhibitors, they only affect noradrenaline increase. Okay, they affect only NET. Then we have one drug which increases the levels of noradrenaline and dopamine. Okay, that drug is called bupropion. But because it has some other mechanisms, we normally classify it as an atypical antidepressant. Atypicals have multiple mechanisms of action, okay? So that is why, even though it is here, you might find it classified as an atypical antidepressant. When you take bupropion, both noradrenaline and dopamine levels in your brain would increase, okay? Then monoamine oxidase inhibitors and the rest of the atypicals, some of them you might be familiar with some of them there. Aside bupropion, the one to be interested in is mirtazapine, okay? Mirtazapine, bupropion, they have a very special use in the management of antidepressant-induced sexual dysfunction, okay? And then agomelatine. That drug has a very interesting mechanism. Aside targeting serotonin, it also targets the receptors for the sleep hormone melatonin. Okay, in some way, someone is able to help the patient to sleep well, and all those things aid in the improvement of symptoms. Okay, good. So before we go to the drug classes and look at the what they have, that's some general points over here. I've already said that when you take antidepressants, they will not work immediately. There will be a therapeutic lag, okay? A minimum of 2 to 4 weeks before you see a measurable response in the patient's mood, okay? Now, the challenge, therefore, is if you have a patient with severe depression, very severe, wants to commit suicide, what are you going to do? Are you going to give her drugs for her to wait for several weeks for improvement? And that is a challenge. So under such conditions, then alternative treatment methods are needed. The most common one is electroconvulsive therapy. Madam Grace, is it in your facility?
Yes, please, we have.
You have it.
And it's really helping.
Use.
Yes.
Right. So what is ECT, electroconvulsive therapy? What are we trying to do? So any comment? Yes. You are jump-starting the brain by what? You are jump-starting. How do we jump-start? You give electric shock, okay? So you shock the brain into convulsion, okay? But now, because they will give muscle relaxant, you don't see obvious muscle convulsions. Previously, the patient would twitch and all that, but now you don't see that. So ECT is also known to disturb the monoamine concentrations in the brain. Okay, so somehow, if you shock, I mean, it's able to create some adjustment in the monoamine levels. Okay, even I have read about cases where just one session is able to do something significant in the person's mood. But this has to be done generally a few times before you see some changes. Then point number 2, the antidepressants are not supposed to be used in depression that is occurring in bipolar disorder. In bipolar, yesterday, Dr. Donné explained you have a swing between either hypomania or mania and depression. So the person is depressed in some period, recovers, is excited at another point. A few times, even both symptoms can even occur together. Okay, something they call mixed mood. Okay, so if you see depression, you have to establish whether the depression is occurring alone, whether it is unipolar, or it is part of bipolar illness. Because the consequence of that is, if you don't check that, is the problem of what is called manic switch. If the person has bipolar and is in the depressive phase, and you give an antidepressant, it will knock the depression off and switch the patient to mania. Are you following? Manic switch. So a number of antidepressants have this property to varying degrees. So antidepressants should not be used alone in bipolar illness. You have to add their proper drugs, the mood stabilizers to it. Okay? And even most of the antidepressants are not even effective in bipolar depression in bipolar. They are not even effective, okay, in the first place. Then another important point, at the beginning of treatment, some patients would experience an increase in anxiety and agitation. And these patients, studies have shown that the increase in anxiety is a predictor even of suicide, subsequent suicide on the medication. Okay? So managing the anxiety and agitation at the beginning of treatment is very important. So normally they will add, say, a benzodiazepine to the prescription, okay, to take care of that aspect. Okay. Then the last point is the discontinuation syndrome. Antidepressants are not addictive. And this point, the pharmacist always has to make this point clear to the patient. Some patients will think this is addictive, they don't want to take it. But they are not addictive. But just like almost all CNS drugs, when you stop taking the drug, especially abruptly, you would experience some discontinuation symptoms. Normally we say withdrawal symptoms. We avoid using withdrawal here so that the patient doesn't think it's addictive. So you use discontinuation syndrome, okay? So because your brain is used to this medicine for months, for years, you can't just stand up one day and decide not to take it because you think you are fine. If you don't take it, you are creating a vacuum. There's a vacuum that has been filled by your drug, producing some level of transmitters. Now, if you just take that away, the brain will struggle to adjust. Okay? So you can deal with this by gradually tapering off the dose. Most CNS drugs are not stopped abruptly. You have to give the brain some chance to adjust by gradually reducing the dose, 10%, 25% decreases per week or every 2 weeks before you stop eventually. Okay. So these are the opening points on the use of the drugs. The next point is efficacy, the effectiveness. Are antidepressants effective at all in treating depression? For a long time, we took it for granted that they were effective until one psychiatrist created a problem in 2008 by studying all the data for antidepressants and came to the conclusion that they are not effective. The effects that we see when we take them are placebo effects. And that created a lot of problems. And the reason was that the drug companies were the ones sponsoring the trials. They would do 10 trials, about 6 doesn't work, they hide it, and then the 4 that works, they submit that to the FDA for registration. So this guy went and gathered all that data. The ones they don't publish, he managed to get some. He combined everything and came to the conclusion that the difference in response between the placebo group during the trial and the people who took the drug was not statistically significant. Okay. So that created a lot of problems. Then people started sponsoring their own studies to counter that on and off. Even 2 days ago, Wednesday, another study has been published that says that they are effective. Okay, in the Lancet. I mean, and they are hoping that that will put an end to all this discussion, but others don't think so. Okay, so others have sat down, reviewed the data, and so what we know now is that these drugs are effective in severe depression. The more severe the depression, the better the benefit, or the higher the benefit you get from antidepressants. If it is mild, the differences are not so much. And the reason the differences are not so much normally is because during the trials, the placebo group recovers, the frequency of recovering a placebo group is normally very high. So your drug, the difference that the drug makes is not normally enough to produce any statistical significance. Okay, people just recover from the depression even without treatment on their own. And there are so many. So it makes it difficult for you to see improvement. So the recommendation normally is that if the...
sorry, I have a question.
Yeah, so let me finish this sentence. Okay. So the recommendation is that if the condition is mild, you go for psychotherapy. And then you allow it to progress. If it's moderate severe, then you give the antidepressants, because the antidepressants are bringing their own adverse effects, you know, to which, so risk benefit might not be so much. Yeah, so.
Okay, I think my question was somewhat answered in your last statement.
Okay.
So I just wanted to be sure whether psychotherapy,
yeah,
in a clinical setting, a trial setting, is not what is really contributing more significantly to the recovery.
Yes.
And therefore, no difference
yes.
in that.
So, I mean, that is why there are a lot of criticisms of or explanations to why the placebo effect is high. The people might be secretly taking some psychotherapy, you don't know. Even the family effect, family members' activities, all these things are not captured in there. So that may be the reason why the placebo group recovers very fast. They are receiving some treatments somewhere, which is not accounted for.
Yeah,
spiritual ones too apart.
Please, since all of us here are pharmacists, I think I want to take the opportunity to maybe make a comment on the part about drug companies hiding information.
Yeah.
Normally, every company, I work in the industry.
Oh, okay.
Every drug company has a research department that when they do the in-house phase 1, phase 2, before they get to phase 3, they get ethical approval and work with clinical setting, hospital and everybody to work. If they do a study and they find that the results that they are getting is not beneficial or better than what the existing practice is, the company take the decision not to proceed further. Because if they commercialize it, it will not give them anything. So that one is an ethical, accepted process. That is not that the product has any information to hide.
Okay. Okay. So
please, what was the point of all that?
No, he's trying to clarify.
No, advocacy.
That was a UN statement.
Advocacy.
It was a UN statement, a statement from the UN. Yes. Thank you.
Well, I think it's fair. Charles is speaking, on the behalf of the drug companies who make some investments, to try and bring some products, but these discussions are always there. I mean, whenever there's a forum on evidence-based medicines, I mean, these discussions are always there. So, I mean, we understand.
It's very important that as we are all in the industry, that perception about industry is something that we should outgrow out of it. If you are a pharmacist in a hospital setting, if you are in research, if you are a clinician, no matter what you do, if the end outcome of getting a medicine to treat the patient is not there, then all the work that you are doing, except maybe the spiritual intervention or psychotherapy that's all coming, drug management has an effective part. And drug management is a place where some people invest to come out with drugs that help to treat diseases. So we should come to realize that there's a department or some people who do that research to come in who are necessary in patient management. And they are necessary that we all accept and collaborate and stop seeing them as sinners who are taking money. If you don't see that people need to make profit to invest in research and come with new medicines, we will get to a time where in Africa, nobody wants to invest in diseases to do with Africa. Because if you do, they will come for philanthropy.
Well said, Charles. But it's already there. I mean, in Africa, how much, research is done?
Say so. Beggars.
Point well noted.
Hello,
can we continue, please?
Can I add to it, support Dr. Bochi? When they examined the evidence that they were saying the difference is not as significant with placebo, they went to the studies, the graph, and they realized that antidepressants start working within a week. And the placebo also starts working within a week. But they depart, when you look at the graph, they depart after, let's say, 2 or 4 weeks. So they came out to say that it's not significant. But it doesn't mean that the antidepressants within 1 week it starts working. But the difference, the placebo effect and the antidepressant effect are the same. And they only depart after, let's say, 2 or 4 weeks. So they came out to say antidepressants only work if you take it after 2 or 4 weeks. So that's one reason to explain why, to support Charles to say that sometimes the interpretation of the results also bring about the difference.
All right. Just one comment from my side. I think that as professionals, regardless of our perspective, if we are all committed to do our job with the highest standards of ethics, this debate goes away. Whether you are in the drug company or the research officer in the hospital, if you look at the data from a very unbiased perspective, with the view of bringing the benefit to the patient, this debate should go away. I don't think there's any point in over-defending any stance. And I think as professionals, that's the stand we need to take.
Well, I mean, I agree that we have the ethical committees, etc., to look at things. But how did all drug ethics come about? It has evolved over the years because certain practices have happened, and then we have put in the checks. So, we started off with you had the, sulfonamide test, then they put in a check. Then you had the thalidomide, then they put in a check. And then you had the Nuremberg trials, we put in the checks. The checks, the Belmont, everything, they have all arisen out of practices, Tuskegee, etc., etc. So it is good that people come out with these things, and then we look at the practice again, and then we put the ethics in place. So keep an open mind. Yes, we are going to do research, but we are also human beings, and people like to cut corners. And so in cutting corners, and we find these things out, then we can put the checks. But if we say we are going to be naive, that everybody is going to be above board, then practices will happen, and no checks will be in place. So I think that is how we should operate. There's a certain level of trust there's always must be that level of trust between the researcher and the community. Otherwise, we can't do any research. But we must also realize that people will cut corners and that we must keep our eyes open so that we can put the ethical principles in place and let us move on.
Okay. Thank you very much. I think we will.
We'll allow for some two more. I see that Tinkran wants to speak. Yvonne, you also wanted to make a contribution. Right.
Basically, Susan has explained what I wanted to say.
Thank you.
Conducting a clinical trial is not a crime. We need research to move science. That is what we should know. And in today's world, research, you can't hide your information. You can never hide your information. So we should note, as scientists and pharmacists, research and their reports will come every day. All we need to do is to have an open-minded, be objective, and have the result and move on.
Okay. Very good. So, Mr. Tinkran, last one.
Yeah, I want to
Susan, your mic is on.
Yeah, mine is on the electroconvulsive therapy.
Yeah.
I want to know some of the side effects of that therapy.
The chief problem is amnesia. You forget interesting memories, long-term memories. After the major problem with ECT is amnesia. Okay, so that is why there are advancements. So there are other advancements. For example, there is a way of using magnetism rather than direct current, something they call magnetic repetitive stimulation, something like that. Those have lower side effects. Okay. But the key one is amnesia. Okay. Madam Grace, anything from practice?
No, courage too is around.
Okay.
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 After ECT, sometimes they feel like vomiting, nausea.
Okay.
They are weak, they are confused, dizzy, and fatigued.
Okay. All right.
Because I know of a patient who was unable to move the limb after he was subjected to that therapy.
Okay.
And up to now, he's been going for physio, but still no improvement. Okay. That's what I'm asking.
Maybe a muscle relaxant was not administered, or there was an underlying condition that triggered, or it could be the medication, Tadif, dyskinesia. So a whole lot, maybe it's been on high doses of the antipsychotics or something. So you have to examine everything. And sometimes we refer them to the physicians to also see if there's any other problem.
All right. Okay, so we shall proceed.
Let me put it on record. Courage has asked for permission. He's doing a presentation at the hospital, so he's not with us this morning, but he will join us later.
Yes, but I am not sure Comfort Anoche has an ECT. I am not very sure. I think I have asked him before. I'm not so sure. But we can confirm when he comes. All right, so it's always important to get a little history of how these things came about. It will help us to remember them. Now, we said chlorpromazine was discovered by chance, you know. So based on the success of chlorpromazine, one lab also synthesized imipramine for the same schizophrenia. But unfortunately, the imipramine was not effective in the schizophrenia. But the mood of the patient, you know, went up a little. So the suspicion that, no, this thing may have antidepressant effects. So he gave it to psychiatrists for a trial on depressed patients, and they became better. And so this started this particular group of antidepressants, the tricyclic antidepressants, okay? So quickly they checked the mechanism, and they found that it was increasing monoamine levels, and they made, you know, extra variations, and so that is what created that class. Then around the same time too, when iproniazid, the friend of isoniazid, was being used to treat TB, the doctor who was supervising the patients on these drugs found that they were, you know, inappropriately happy, okay, when they went on. That was his expression. So he suspected that, no, this thing was elevating their mood, okay, so when they checked the mechanism, they found that it was affecting monoamine oxidase enzyme. It was inhibiting it. They tried it in depressed patients. It was effective. So that is the genesis of that group 2, monoamine oxidase inhibitors. So between 1961 and 1980, based on these 2 leads, a number of antidepressants came out. The monoamine oxidase inhibitors there, phenelzine came out, tranal, cypromine. Then there's another one, isocarbazepine. They all came around that time. Then for the tricyclic side, imipramine came, the cipramine, dozepine, protriptyline, nortriptyline, and all this came later. Okay. So you can consider these as first-generation agents. Okay. Now the challenge is that all these agents have so many side effects, very troublesome side effects. There was a need for better tolerated agents. So that started another movement, where in 1987, they were able to synthesize a compound that was selectively inhibiting the serotonin transporter. Okay, because the belief was that if you can get only serotonin up, the side effects should be reduced. Okay, so Prozac became that wonder medicine, and it was highly marketed with the monoamine hypothesis that there is a chemical imbalance in your brain if you have depression. So take this to, increase serotonin, and so that became popular. Then later, we had other SSRIs, sertraline, paroxetine, citalopram, and then somebody also discovered that no, if we can still get noradrenaline also in, but without the other problems of the tricyclics, then maybe we can get an agent that is better. And that is what started the SNRI group, the serotonin, noradrenaline reuptake inhibitors, venlafaxine and their other groups. So you can consider this as recent generation, second generation agents. Okay. So let's look at the drug groups from the most popular to the older troublesome ones. So we start with the SSRIs. Okay. Currently, they are the first line antidepressants for depression as well as anxiety disorders. Okay. And the reason simply is that they are more tolerable compared to tricyclics or monoamine oxidase inhibitors. And one problem with tricyclics is that if you take overdose, it kills you. You have arrhythmia, excitation, convulsions, coma, then you die in overdose. Okay, so a depressed patient who wants a means of committing suicide, will use your drug to die. Okay, so SSRIs were therefore, because of the safety in overdose, became very popular. So if you look at the structure, the examples already, the mechanism already, but just to add that, aside the blockade of the reuptake of serotonin, they have other secondary effects. They interact with some other receptors that will give them some added advantage. Okay, for example, citalopram is highly antihistaminic. When you take it, it's very sedative because of those additional effects. Okay, right. So fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram, and the enantiomer of citalopram, S-citalopram. Okay, they have very similar efficacies, as we said earlier. The differences mainly are in the side effects. Citalopram beyond 40 milligrams a day causes arrhythmias. Okay, that is why the dose is down. You might find a range from 20 to 60 in some sources, old sources. They have reduced it to 40 because beyond that there is QT, corrected QT elongation. So that can lead to ventricular tachyarrhythmias. And the next point to take note of is that sertraline has been shown in several studies to be safe in those with heart disease. okay? Either with unstable angina or those who have had myocardial infarction. So if you want to give something to an SSRI to somebody with those problems, I mean, sertraline is safe. Okay, so you can even see that it's becoming popular in the system, okay, as the preferred SSRI. A little about the pharmacokinetics. Absorption is good when you take it orally. Metabolism depends on liver enzymes, and some of the drugs are inhibitors of liver enzymes, so drug interactions are possible. Then fluoxetine has a very long half-life. On continuous dosing, I think it's between about 4 to 6 days. That's the half-life. Then it has a metabolite, norfluoxetine, which even has a half-life of about 16 days. So when you are on fluoxetine, the drug will be in your system for a very long time, even after you've stopped taking it, okay? So fluoxetine or SSRIs are not supposed to be combined with monoamine oxidase inhibitors. I will explain that later. So what it means is that if you are taking a patient of fluoxetine, you are switching to a monoamine oxidase inhibitor. You have to give time. Even after you stop the fluoxetine, you need to give enough time for the drug to leave the system before you introduce the new agent. If you don't, there will be a drug interaction. Okay. Then the adverse effects. So we are saying that these are more tolerable than the other ones that we talk about briefly. So GI symptoms are there. Some will experience nausea, vomiting, diarrhea. Then some will experience headache. Others, insomnia. And the insomnia, it's not everybody. The people react differently to some of these medications. Some take the SSRI and they are drowsy. Others take it and then they can't sleep. Okay, I know of sertraline, sertraline's behavior. If you make a mistake and you take it late afternoon, if you want to sleep, say 9, you can't. The sleep will not come until maybe around 3 or 4 a.m. once the plasma levels have gone down. So it depends on the individual, and I think there are slight variations within the individual agents. And then fatigue. You take these drugs and you feel tired. You know already the symptoms of depression include tiredness. So it makes it worse. It makes it worse. Then the anxiety I spoke about earlier in some patients at the beginning of treatment, they can take benzodiazepines to help in that. The next adverse effect is in red, sexual dysfunction, because it's very critical for adherence to treatments. And we are saying that these drugs, you have to take them religiously for a long time before you see an effect. Okay, so adherence is very important. And so you take these agents, and after a while, you realize that sexual performance is affected. Libido goes down, which is already down in the condition. It makes it worse. There is erectile dysfunction for males. Then orgasm issues, it doesn't happen. The ejaculation is delayed, okay? And this is a problem for somebody who is already struggling with libido issues, okay? So you have to extract this information from the patient. They won't tell you willingly. So you have to extract this information and then deal with it and treat it. I'll comment on the treatment briefly. But the other side of this is some good news for those who have premature ejaculation. So these side effects can be critical for those people. Okay, so when you find SSRIs, they may not just be for depression. They may be for premature ejaculation. Okay? And the worst culprit when it comes to ejaculation delay is paroxetine. It's so effective in delaying ejaculation. So this is there. The risk of bleeding. You want to
Yes,
say something?
the sexual dysfunction part and premature ejaculation. That means that such a patient specifically will have to have a very strong erectile function, because here it's also going to compromise.
Yes, it's going to compromise. So occasionally you add the other groups to it, the vagal group, even to solve that aspect of it. You see, yes. Mm-hmm.
So maybe the person is depressed because they are not performing already. That is why they are depressed.
Yeah.
Then you come and give them this.
Then it makes it worse. The little there vanishes. The little that they are able to get vanishes. So, I mean,
so it makes
it's worse.
So it makes Viagra very necessary. Very necessary. Because sometimes you need the Viagra to break that cycle.
Okay.
Give him that confidence.
Mm-hmm.
So you break the psychological part.
Okay.
Then you can continue with the chemical.
With the chemical part. Okay. Okay. So maybe I should just talk about the management, before we proceed.
Dr. Boji, there was one thing you were going to say that is of interest about the bleeding aspect.
Yes, I'm coming to that.
Yeah.
So let me talk about the management of that thing, then we continue with the other effects. So there are a number of approaches in treating the dysfunction. The first one is just to wait, just have some patience. For some patients on the drug, tolerance can develop to that adverse effect. Okay, so they can recover after a few weeks. Some will not. If you wait and wait, it gets worse. So you have to try something else. You can reduce the dose if it is possible, if it won't compromise on the response of the patient, then you can reduce the dose, especially if you're at the very high end of it. But if you just started at the lower doses and this is happening, it means you can't reduce it further. So the next option will be to give drug holidays. I have read a paper where they found that for, say, sertraline or paroxetine, if you skip the Thursday afternoon dose and then you start on Sunday morning, if you are taking it BD, okay, you skip the Thursday afternoon, so you have Friday, you have Saturday, then you start on Sunday morning. They are able to recover some of their lost functioning, okay? So that helps some people, okay, with those drugs. If that doesn't work, then antidotes. Bupropion, I mentioned bupropion, sildenafil, mirtazapine, cyproheptadine, methylphenidate. These ones can be added to the drug to correct this. Or if this also is not working, then you switch entirely to either bupropion or mirtazapine that are free of such side effects. Okay. So back to the bleeding issue. All SSRIs increase the risk of bleeding, especially GI bleeding. And the risk is higher if you add NSAIDs to it. Now, what is the mechanism? Platelet aggregation is important for controlling bleeding. So whenever there is damage to a vessel, platelets will come together, form a platelet plug to seal the entrance and start the other mechanisms of stopping the blood, the bleeding. Now, the platelets need serotonin to aggregate. The mechanism of aggregation is dependent on the release of serotonin. And platelets do not make serotonin on their own. So they take up serotonin that has been made as they float around. Then they take the serotonin through the same serotonin transporter. That is at the nerve ending that we are talking about. The same thing is on the platelets. So when you take the SSRI, it's not just going to block the transporter in your brain. It's going to block the transporter also on the platelets. So the platelets are not able to pick up serotonin. And so when there is a need for that mechanism to aggregate. They don't have serotonin to release, to invite their friends to come together to form the platelet plug. Are you following? So that increases the risk of bleeding. Now, it is worse now if you are on NSAIDs that also reduce the suppress clotting mechanisms. If you are on soluble aspirin, for example, with an SSRI, there is trouble, because that is also going to use an alternate mechanism, affect prostaglandins, reduce the risk of clotting. And then in the GIT, we know what NSAIDs can do in, how do you call it, promoting GI bleeding, okay, by their effect on prostaglandins and all that. So you add the two together, and the risk is even higher, okay? So do not give SSRIs as much as possible. Do not give them with NSAIDs. You can try paracetamol. Paracetamol for pain is okay. If it comes to the inflammation, then that's another trouble. If it becomes very necessary, they recommend gastroprotectants, okay, for those who are at risk of ulcer and those kind of things, okay, to deal with it. Any comment here?
Yeah, there was a case at Confanochi. This woman had, in fact, the woman, it occurred at our hospital here.
Okay.
The woman had this hemorrhagic stroke.
Okay.
And she was showing some neurological deficits. Then they prescribed fluoxetine.
Okay.
I raised a query, but I was told that it's a practice at Confanochi. Well, maybe those from Confanochi can explain that. Okay. That's why I was interested in knowing the effect of these drugs on stroke, especially the hemorrhagic types.
Okay. So on the prescription, have you checked to find out if there is any countermeasure?
Those none.
Okay, so probably there might be a countermeasure. If you can adjust the doses in a way that will minimize the effect of the other drug, or you can add something to it to minimize. There are things like that. Okay, so it's not just enough to look at the fluoxetine and those agents, but are they doing anything else to counteract?
Please,
okay,
I
so
can
as you want to say something?
Yes, fluoxetine in stroke patients, they get depression, a type of depression. They get depressed, and also for their motor function. Research has shown that fluoxetine also is beneficial for improving the motor function. You know, they are not able to move their, so it's added double benefit.
Is it all type of stroke or the ischemic type? If there's ischemic type, I have no problem. But if it's hemorrhagic, and what Dr. Boti is saying,
bleeding.
Yes, if the person is having active bleeding and you give that, will the risk be more pronounced?
The risk is
more. I'll follow up with that.
So the risk is more. So what we are talking about is what is done to control the risk, to reduce it.
Yeah, please,
because
I want to come in.
The fluoxetine is very important for the depression associated with the stroke. So that something has to be given. We don't have any option. That is what we want to give. So it means we need to minimize the risk with some other agent.
Then maybe you give us, you are informing us, you switch from SSRI to the other one, just that they will be more expensive.
Any uptake inhibitor that affects serotonin would increase the risk of bleeding. You don't have a lot of choice.
Yeah, just to add to that.
That's the challenge.
Dr. Wochi,
yes.
I'm here.
Francis, if you hold on, please. If you are not speaking, if you could put off your... Okay.
Okay. Okay. So where is Francis?
I'm here.
Okay.
Yeah, a house officer once prescribed fluoxetine for a stroke patient. I asked about that, and then he said he referred me to a study, even though I have not read it. He said FLAME study, that there was a study called a FLAME study, and that's, even though I have not read it. So he quoted that study to back the prescription of the fluoxetine in the stroke patient, which I haven't read.
Is it that the risk is minimal, or?
In fact, I haven't read that study.
Oh, okay.
But he just referred me to the FLAME study. Yeah.
All right. So what will happen is that when the practitioner comes, fortunately, he was at Confanochi, then we would throw this to him so that he will tell us what they do about such. Even is the risk even important? Is it an important risk? I mean, he will tell us about it. Okay, so we can proceed. There is some evidence that extrapyramidal symptoms can occur with SSRI use. Just that the risk is minimal, but it is possible, especially if you combine it with some antipsychotic. Then know that the risk could be higher. Okay. Then another danger adverse effect here, serotonin syndrome. Serotonin syndrome. This is a problem with any it's a problem with any drug that increases serotonin levels in the brain. Okay, so if you combine an SSRI that increases serotonin in the brain and you to another agent that also increases serotonin in the brain, the collective effects leads to a state where there is so much serotonergic activity in the brain. So it's just too much. So it creates a lot of problems, okay? And so there are a group of symptoms. So it's called the serotonin syndrome. So I'm using this to explain that. So the first thing there, of course, is fever. Just like we saw for neuroleptic malignant syndrome, there is fever, rapidly rising fever. Okay, temperature goes high. There's agitation, the autonomic instability. So pressure fluctuates. Typically, it goes up. And then you see tremors, and the reflexes are high. And some patients would also have diarrhea, okay? So it's a very serious thing if you do not attend to it quickly. I mean, it can be fatal, okay? So the treatment approach one is to discontinue the drugs that you are using. And then most often, once you deal with the symptoms, the patient is fine. A few cases, it can be severe. You have to give counter serotonergic agents, serotonergic antagonists, like cyproheptadine or methotrexate, to control it. There's also muscle rigidity, and that can also be treated with dantrolene. So the point I'm making is that the drugs on their own can produce serotonin syndrome if you give very high doses. Then serotonin syndrome can also arise if you combine them with another agent that is raising serotonin levels, okay? So typical example, your patient is on fluoxetine and then has headache. You don't prescribe tramadol for the patient because tramadol increases serotonin. As you shall find, it's an SNRI, okay? So it raises serotonin, so there can be a problem. You don't combine it with petidine. Petidine can increase serotonin levels. So you have to choose your the drugs that you give with it very carefully. Okay. Then we've talked about discontinuation syndrome already. I'll say something about it later. So the other drug interactions can occur if you give the SSRIs with other drugs that are highly bound to plasma proteins or that inhibit liver enzymes, okay? So you can have interactions from there as well. So in summary, the indications are this: major depressive disorder, first line. The SSRIs are first line. However, for those below 18 years, the risk of suicide in these patients outweighs the benefits. Okay, the effect is not so much. And then all antidepressants increase the risk of suicide, okay, especially at the beginning of treatment. And the risk is very high in those under 25 years, okay? So for all the studies done, it is only fluoxetine that appears to be useful in people of this age, okay, those below 18 years, okay. Then SSRIs are also first line for anxiety disorders, as you said, and these other related psychiatric illnesses. We will comment briefly on this and the anxiety disorders, and then premature ejaculation. The other newer class of drugs is the SNRI, the serotonin noradrenaline reuptake inhibitors. Venlafaxine, the popular one, desvenlafaxine, duloxetine, and milnacipran. Then there are two drugs there, sibutramine and tramadol. They are not classified typically as SNRIs, but they have SNRI activity. Okay, so tramadol is a weak opioid for pain, but it is also a weak SNRI. And you know why tramadol is popular these days? The SNRI effect is part of it, the ejaculatory delay. The same ejaculatory delay for SSRI is here also with the SNRIs. So tramadol can delay ejaculation, aside the euphoria that it creates. Okay, so that is why young people will be running after it. And the advantage too, of course, is that it works on demand for premature ejaculation. The SSRIs for premature ejaculation will also have to be taken for some time. You need some 2 weeks to get serious effects from it. So if I say on demand, it means that you can take it 3-4 hours and then the effect comes. For whatever you use it, then it leaves your system. Are you getting the point? You don't want to be taking a daily dose of a drug because, you want to. I mean, you can't do that for the rest of your life. Okay, so these are the issues. Then I want you to take note of venlafaxine. Venlafaxine is becoming very popular as an alternative when you try SSRIs and they don't work. It's something that they switch to. At doses lower than 112.5 milligrams per day, it doesn't show any norepinephrine reuptake inhibition properties. It behaves just like an SSRI. So if you want the additional benefit of the norepinephrine uptake, you have to give doses above 112.5. The common one is you give about double of 75, okay, 150. And then you begin to see the additional benefits of noradrenaline inhibition. So the indications are also similar, except that one advantage of this group is that they are also effective in treating chronic pain disorders, okay, particularly neuropathic pain. So if you have a depressed patient with, serious pain symptoms, body pains, lower back pain, etc., you can give venlafaxine for both the depression and the pain, okay? Then diabetic neuropathy, all these other things are useful for this group. Then tricyclics. So we said imipramine was the first one, tofranil, and then the others followed. The basic mechanism is that they are increasing 5-HT, serotonin, and noradrenaline levels. But they also interact with a host of other receptors. Most of the problems that tricyclics have is due to the interaction with other receptors beyond the transporters that they are blocking, okay? So they affect H1 receptors, and what CNS effect should we expect from H1? Sedation, and consequently weight gain, okay? Alpha receptors, what's the implication? When you block alpha receptors on blood vessels, hypotension, okay? So hypotension is an issue there. Muscarinic receptor blockade. You have anti-muscarinic effects, dry mouth, tachycardia, urine retention, and all the host of others, okay? Then they also block sodium and calcium channels, and this will be critical for cardiac toxicity, okay? So they can produce arrhythmias, serious arrhythmias, if you take more than necessary, okay, because of this. So the available tricyclics. Okay, I've put the structure of imipramine there just to emphasize the tricyclic thing we are talking about. Okay, so imipramine, and imipramine is metabolized in the liver to desipramine. So when you take imipramine, it is active, but the metabolite is also active. Okay, desipramine. Amitriptyline, metabolized to nortriptyline. Okay, and then clomipramine. Then the others, which are not so common, duloxetine, dozepine, and all these other ones. Efficacy is very close. They have almost the same efficacy. The differences are insignificant. So the choice will be based on the adverse effects. For example, amitriptyline is very sedative compared to imipramine. So if sedation is what you want, then you choose that one. But imipramine is also more antimuscarinic than amitriptyline, particularly on the bladder. Okay? So if you want to treat enuresis, for example, then you can use imipramine because it retains urine. Okay? So you can use that to control enuresis, especially in children, nocturnal enuresis. So the indications here again, tricyclics are not first line because of the side effects. They are not. So you have to try SSRIs, SNRIs first. If they don't work, before you think about a tricyclic. That is what is done elsewhere. So the Ghana psychiatric pharmacists, is that what we do here? Or do we start with tricyclics? Or we start with SSRIs?
We start with SSRIs, but not the other specialties. They still use amitriptyline, but as you are showing, it's very effective, just that the risks of suicide.
Yes.
So we have to do a change. If in any of the other disciplines, they still write it because of the other advantages amitriptyline.
It has. Okay.
But
all right. So it's because I see prescriptions of those things. That is why I'm asking.
We need to do the education.
Yeah, okay.
We also have to be mindful of other indications
of it.
Yes. It's not only what they call it for the mood disorders, but the tricyclics are also used for other indications, for which is also effective. Yeah.
Migraine.
All right. Okay. So the other indications are there. For premature ejaculation, clomipramine is also used. If you want to pick a tricyclic, clomipramine has a very strong serotonergic effect compared to the noradrenergic effects. And there are studies that show that tricyclics may not be effective in children. Okay? And they will be especially good for severe depression, especially in hospitalized patients. Pharmacokinetics, the key points I want to make, because of the strong binding to plasma proteins, and they are highly lipophilic, so they are distributed in body fat. Because of these two reasons, in case of overdose, dialysis is not an option because they won't get filtered out of blood by dialysis. They will be stuck to the plasma proteins. So you don't waste your time doing dialysis. Okay, so you just treat the symptoms and you allow them to come out, in their own time. Okay, right. The plasma levels relate to the efficacy. So if you are having challenges with response, you can also check the plasma levels. Probably the patient is not taking the drug, or there are some interactions that are reducing the plasma levels. You can use that to verify. So these are the adverse effects. We have already mentioned a lot based on the receptors we were talking about. Okay? So anticholinergic, alpha blockade, H1 blockade for sedation, drowsiness, and all that, sexual dysfunction, cardiotoxicity. Okay, you tend to see this at high doses, not at regular doses, including the neurotoxic adverse effects. Then again, if you stop abruptly, there will be withdrawal symptoms. So because of the risk of your patient using the tricyclic to commit suicide, there are a few precautions that we can take, and this is very critical for us as pharmacists. Patient education. A patient on a tricyclic for depression should be educated to understand that the drugs do not work immediately. So if you go home, you take 2 doses, and you are still feeling sad, tired, and all that, you don't think it's because the dose is too low. So you unilaterally increase the dose on your own. Okay, that can lead to, toxic effects. Then the clinician is supposed to prescribe only limited quantities so that the patient doesn't have the luxury of plenty tablets to swallow. And then if you suspect that the patient would want to commit suicide with your medication, then you have to admit them and make sure you reduce the risk before you send them home. Okay, you treat them on the ward for some time. Okay. So in case the person takes overdose, what are some of the features? The heart and the CNS is the main target. And of course, the blood vessels. So you see the patient presenting with confusion and excitement. This can progress to convulsions, and then death can result from respiratory depression. Then cardiac arrhythmias, particularly ventricular arrhythmias, can also result, which can lead to death, together with hypotension, that results. So what can you do? If you identify the patient is intoxicated by tricyclics, there should be cardiac monitoring, so that if arrhythmias are happening, you support the airways because of the respiratory depression. You can do gastric lavage, if that is possible. If seizures appear, you treat with benzodiazepines. And occasionally, they can also alkalinize the blood to reduce the effect of the tricyclic on the heart, okay? To remove the drugs from the sodium ion channels in the heart. That is also helpful. But as I said, hemodialysis, hemoperfusion, ineffective because of the high volume of distribution. Okay. Interactions, I can skip this. They are similar to some of the things we have seen. Ribosatine and maprotilin belong to noradrenaline reuptake inhibitors. Unfortunately, ribosatine is not so effective, so it's not so popular. Okay. Then monoamine oxidase inhibitors. They are reserved only when all treatments have failed, okay, because of their adverse effects and the interactions that they cause. And they can be abused also because when you take it, even without depression, you can get some euphoria, okay? So that should be monitored. We've looked at the mechanism already. There are 2 groups of these drugs. We have the traditional monoamine oxidase inhibitors, also called the irreversible non-selective inhibitors of monoamine oxidase. We said there are 2 isoenzymes. So it's only one that is important for depression. But these drugs inhibit the 2 throughout the whole brain, okay, and even in the periphery. And once they inhibit the enzyme, the activity of the enzyme is lost until new enzymes are formed to replace them. And the replacement can take between 1 and 2 weeks. So it means that when you take a monoamine oxidase, its effect, even if you discontinue the drug, will last for up to about 2 weeks. So assuming that you want to switch from a monoamine oxidase inhibitor to an SSRI, for example, then it means you have to wait for 2 weeks after you discontinue. If you add SSRI, there can be serotonin syndrome, okay? Right. So phenelzine, isocarbazazine, tranylcypromine, they are in that group. Then they were able to make one agent, moclobemide. It's a reversible inhibitor of just the important, isoenzyme, monoamine oxidase A. And because the interaction is reversible, its effect will not last for 2 weeks like the other ones. Okay, the effect can easily be reversed. Now, selegiline. Selegiline, what is the popular brand of this drug for Parkinson's? It has a popular name, which I have forgotten. Selegiline. Who is familiar with it? Is it Cinemet or Cinemet? Cinemet. Cinemet. Okay. I think it should be around that.
Cinemet is a completely different product.
It's different.
Yeah. Amantadine is also another.
Amantadine is Cinemet.
It's Cinemet. Oh, okay.
So they usually just write Cinemet. They just write Selegiline.
They just
the
write
brand
Selegiline.
name is also in the same, similar to the.
Oh, okay. Okay. All right. So that's just by the way. But Selegiline traditionally was used for Parkinson's disease to raise dopamine levels. But they have found later that if you get high concentrations of Selegiline, it loses its selectivity for the monoamine oxidase B type. So it can begin to affect A, which will be useful for your depression. Now, how do you get high levels of Selegiline into plasma? Because it undergoes a lot of metabolism. Okay, so one company has been able to design a transdermal system, a transdermal patch. So when you apply it, you are able to get high concentrations quickly into blood, which will be able to stimulate, inhibit the other isoenzyme. Okay, so I think it's only one agent. So it has, I think it's called MSAM. Okay, I don't know if anyone has seen it around. It's a very recent thing. So Selegiline transdermal patch is also indicated for depression. So indications, as I've said, last line, if everything fails, if the depression is also very severe, with lethargy and poor motivation, all this can be used. And then in atypical depression or depression with atypical features is where you have the individual. Yesterday, Dr. Doni was talking about the paradox with weight and sleep. So some will gain a lot of weight, others would lose weight. Some will sleep a lot, others will struggle to sleep. So those who eat large bits in pieces, who gain weight, also tend to sleep a lot. And they also are more sensitive emotionally to relationship issues and what people think about them. So they belong to a subclass of depression with atypical features. They normally have a lot of low energy, so much so monoamine oxidase inhibitors are particularly useful in this subgroup of people. Okay, right.
Okay, for your information, Cinemet is carbidopa-levodopa combination.
Okay, so I'm confusing it with some other anti-Parkinsonian agents. Okay, right. So adverse effects, I'll just keep this, you can look at this, so that I'll talk about the major reason why it's very difficult to prescribe monoamine oxidase inhibitors, particularly the traditional ones. The interaction with foods containing tyramine. I hope you are familiar with this. The cheese reaction. If you are on a monoamine oxidase inhibitor, and then you take foods containing a lot of tyramine, then you have hypertensive crisis. The reason is that the combination of these two leads to high levels of noradrenaline in the brain. And so that manifests as excessive sympathetic activity that leads to very high blood pressure. Tyramine is produced from the breakdown of the amino acid tyrosine. Okay, wherever there is fermentation of protein and you find tyrosine, tyramine will be formed. Okay, so fermented stuff, things with a lot of protein that are fermented will most likely contain tyramine. Okay, so patients on monoamine oxidase inhibitors, particularly the traditional ones, should avoid things like ripe cheeses, contain a lot of tyramine, wine, beer, yogurt, soya products, and a few other ones, banana peels and some other things.
Pito.
They are very pito.
Yeah.
Okay. So if you are on phenelzine and those things, don't go and drink beer or wine. You end up at emergency with very high blood pressure. And if you are not lucky, you get stroke from it. Okay. So the risks are minimal with the reversible ones and the MSAM that I have mentioned. And the interactions are there. Serotonin syndrome is possible. Okay. And then quickly, let's talk about the atypicals, and then we can end with the antidepressants. So as I said, these are drugs with multiple mechanisms of action. They may have reuptake effects, monoamine oxidase inhibition. They can block receptors, okay? And so the two, bupropion and mirtazapine, are very popular because after trying the SNRIs and you don't see effect, they are the ones that are typically tried before you even come to tricyclics. Okay. So bupropion inhibits the uptake of noradrenaline and dopamine, but the exact mechanism is still not clear. And we know bupropion also to be used to treat nicotine addiction, isn't it? So it has anti-craving properties. So if your depressed patient is also likely to be abusing substances, to smoke, okay? So if the person is struggling with smoking and is depressed, when you give bupropion, you can help with both the depression and the smoking, okay? It's also useful because it is one agent that leads to weight loss. If your patient is gaining weight on some other antidepressants and is creating problems, bupropion will cause the person to lose weight. Okay. The only challenge with bupropion is the risk of seizures. It reduces the seizure threshold. In fact, all antidepressants, especially those that affect noradrenaline, increase the seizure risk a little. But bupropion's risk is very high. Okay? So avoid in those with history of epilepsy, those with bulimia, those with this binge eating condition. These people, they have some anxiety-related disorder. I think they are obsessed with self-image. And then they will eat a lot at some time, and later they will go and vomit it out. They want to deal with the excess calories they think they have taken. They will go and force and vomit the stuff out. Okay? So these people normally have electrolyte imbalances, which increases the risk of seizures. Okay? And then heavy drinkers. You know the challenge with alcoholism is that alcohol withdrawal can produce a seizure. So, I mean, that is why you should avoid this. Bupropion doesn't affect sexual function. So it can also be used for that. Mirtazapine too, in the same fashion. I have already spoken about ketamine. This is an emerging treatment for depression. Fast-acting, sub-anesthetic doses of ketamine. It's even useful in treatment-resistant depression. You try everything, it doesn't work. You infuse ketamine, and within a few hours, the symptoms are gone. Just that after a few days, you have to go back again for another infusion. I mean, that is not sustainable. Okay, so there are efforts to get better drugs that work through its mechanism. The other unique thing about it is that it has a specific effect on suicide ideation, independent of the depression. If you want to die and they infuse ketamine in you, you forget about the dying. So that is also an advantage that is there. A number of herbal preparations are also there. In the developed countries, St. John's wort is popular. We also have our versions here. Okay. Interestingly, that is some of the things that I do. Okay, we've established antidepressant effect of a number of things, including xylopia, isn't it? Xylopia. What is the popular local name? Okay. Yes. So, I mean, you can add a little of that to your food, and it will always make you happy. Okay, so I have a few points left so that we can pause on the antidepressants. The discontinuation syndrome. As we said, you don't have to stop the antidepressants abruptly. You taper the dose. So if the patient stops abruptly, within 3 to 5 days, there would be serious discontinuation syndromes. Most of the symptoms are like flu, okay? So you have some body ache and headache and running nose and paresthesias, anxiety, and a few things will come in, dizziness, and the rest. And the risk is high with paroxetine and venlafaxine. The reason is simple. Their half-life is very short. So when you stop abruptly, within a few hours, the drug leaves your system. And so the body is exposed. But if you are on, say, fluoxetine, whose half-life is very long, you will hardly find this problem, okay? Because the drug takes a long time to leave your system. It is tapering on its own, okay? So management is to reassure the patients that the problem is temporary, to go, so they shouldn't be excited. And if you are having problem controlling the symptoms, what can be done is that you put the person back on fluoxetine, and then you taper the fluoxetine doses, okay? So once you take the fluoxetine, the syndrome will stop, and then you have time, and then you taper the doses. I have spoken about the suicide problems again. I think, I don't know who made fluoxetine, which company, it has escaped me. Okay. I think they struggled with a lot of lawsuits because of this problem. People began suing the company because of the increased risk of suicide, okay? So the patient is already having problems with suicide, but the drug is making it worse, okay? So when they studied this, they realized that the risk is higher for those less than 25 years, okay? For those less than 25 years. And a number of explanations. One interesting one is that, you know, because in depression, we learned that the person has low energy. They have low energy. Then they have emotional issues. They are feeling worthless. They are feeling worthless. Then they have some other emotional symptoms, low self-esteem and all that. When you start the antidepressants, it is believed that the low energy problem improves earlier than the emotional symptoms. So when the person now has energy to be able to commit suicide, the suicidal thoughts are still there. So they have energy now to commit the suicide. I follow it. That is one common explanation for why that happens. So you monitor those under 30 years, close monitoring for the risk, supply limited quantities, as we said, And if you start treatment and the person responds with marked agitation, that should give you a sign that the risk of suicide is high. Okay, so you have to keep a closer look at that. So I'll skip all this and pause here for any comments or questions. Then I have about 6-7 slides for bipolar. So if you can stretch ourselves.
My question comes back to when you said there's not much difference between placebo and therapy, drug therapy.
Okay.
So now that we've gone through all these drugs and what they do, and in your practice, what is the role of drug therapy in management?
Yeah, so as I've said, it works in moderate to severe cases. That one, the evidence is there. There is no controversy over that one. But it's mild cases that the evidence is not very strong. It is possible that it works, but it's an evidence issue. We are not able to show clearly that from trials because of the high placebo, response rate. Okay, so it works, but it works in people typically whose depression is moderate to severe. So if it's mild, try psychotherapy first before you go on antidepressants.
I have a question.
Okay.
This discontinuation therapy and withdrawal syndrome,
Yes.
discontinuation syndrome and withdrawal
Yes.
syndrome, are they one and the same or there's a difference?
Discontinuation
And withdrawal syndrome.
Yes, there is a difference. I mean, that is why the name has changed to discontinuation. When you use withdrawal syndrome, people tend to associate that with addiction. Okay? Formerly, they used to classify the condition where somebody struggles to stop taking a particular medicine. They used to classify it into 2 groups. You have psychological dependence and physical dependence. The psychological dependence is now called addiction, and the physical dependence is just called dependence now. So you hear addiction and dependence. For addiction, you have a change in the reward system of your brain, the system that helps you experience pleasure. There is a problem because you've taken the drug for some time. It has caused a modification in that system. So you now develop craving when you stop the medication. That is addiction. Okay. Then for dependence, you are finding it difficult to stop taking the drug, not because there is a craving for it, but when you stop, you have withdrawal effects. Are you following? That is why you want to take it so that you feel fine if you stop. Okay, so in order for patients not to associate these symptoms with addiction, they've stopped calling it withdrawal symptoms. They are calling it discontinuation because you are on the drug for a long time. If you want to stop, you have to give the body a chance to adjust. So they are not anything that you should be afraid of. Okay, they will stop on their own.
Okay, as a follow-up, does it mean steroid use, we should be using discontinuation syndrome instead of withdrawal syndrome? Because
yeah, I mean that would be that
would be the logical conclusion.
Once there is no craving, no psychological issues where you have some inbuilt desire, even if you stop after 5 years, you see a particular cue, you see a particular environment, you remember that, hey, I used to take this drug, I need it, then you go and get some. No.
Okay.
Okay.
Thank you.
Right. Any other? Okay.
Yes, I just remember maybe on a lighter note. Okay. So the name, the nomenclature changed from withdrawal to discontinue.
Just to make patients feel comfortable.
Okay, so in my setting, for example, I can choose another name to make patients more comfortable.
Ah, well.
Like an adjustment.
Adjustment syndrome. Well, it needs to be a standard nomenclature, something we all agree and understand. So if you choose your own, it will be very difficult for us to relate with yours. Okay. So we all have to agree on the name before we start using it. So the current agreed name for this one is discontinuation syndrome. All right. So.
Yes, sir.
Okay.
Please, I wanted to find out, apart from using clinical symptoms and signs to maybe diagnose depression, is there any other way, like?
No, there is no objective way of determining that. The diagnosis is based purely on symptoms. Okay, they have tried to search for. You find something you are excited about, but you don't find it in other depressed patients. So it makes it complicated. For example, the hypercortisolemia, the high levels of cortisol thing. The people thought that, oh, this is a very good test, but it doesn't happen in everybody. So if you use that, you might not be able to detect depression in everybody. So that's the problem.
Okay, so Nicodemus. Speak to your mic.
So it's not working. Yes, the things I mentioned there, I mentioned 3 things: the erectile dysfunction, anorgasmia, that can occur in females. Okay, that is their symptom. Okay, and then ejaculatory delay. Okay, that one to some extent, but female anorgasm, they don't achieve orgasm. Okay, so I mean it occurs in everybody. That particular one occurs in everybody. No, it can be diagnosed. So that is what we are saying, that there is a study that found that patients with sexual dysfunction will not openly tell you that they have sexual dysfunction. But you have to push and extract the necessary information. So you can extract all those symptoms. You can have a way of finding out whether there is anorgasmia or not, or erectile dysfunction. It depends on how you interact with the patient. All right.
So maybe just...
Yes. So we should be concerned about the females too. That is what we are learning.
Okay, to add, the partners come complaining that let's say the patient is a female.
Okay.
The partners will come complaining. They've lost interest in having sexual relations. Or less lubrication. If you touch them, they don't feel anything. I mean, they don't respond to all your skills. Yeah. Then
just a continuation of Alaji's question. So there's no way to diagnose. How about monitoring? How do we monitor sources if somebody's on treatment?
So that is psychiatry. That's the diagnosis. If Dr. Donne comes, maybe you have to ask him to explain. There are, in the diagnosis of this, they use questionnaires to score. Okay, the popular one for depression is HAM-D, isn't it? The Hamilton Depression Scale. So you answer some questions, and then they'll score it. And so they have a limit. If you get above this score, you have mild depression. If you get above this. Yes. Yes. So for drug response, for example, there's a limit. If you have a score of this, then we say you have responded. If you have a score of this, you have responded to this extent. Right.
Doc, I wanted to find out, this antidepressant, is it possible that they would push you into mania?
Yes, we've said that. We've said that, we've mentioned manic switch.
Okay.
That if you are depressed, but that depression is part of bipolar, then the antidepressant can kick you into the manic phase. Okay. So that is the risk of a number of antidepressants, I mean, when you take them alone. So I made that point at the beginning that they are not supposed to use as monotherapy in bipolar, okay, because of that problem.
Yeah, the second one, I also noticed that mirtazapine, usually they will tell you to give it after 15, a dose about 15 milligram.
Okay, mirtazapine.
Yes.
Okay, I'm not familiar with the use of that agent.
Oh, okay.
So, yes. Is there any other? Okay, Dr. Bobby, are we going to stretch a little? I have a few slides on the bipolar side. Should I proceed?
How about if we take our snack break?
Okay.
And then we come back.
We come back.
Yes, since Dr. Dune is coming at midday.
At 12.
Yes. Okay. So we take our snack break, and then we come back. A few announcements. We have the YouTube link for those who missed yesterday's lecture. You know, it's been recorded. So if you go to the YouTube channel, e-learning, KNUST. The name of the program is Pharm. So each YouTube channel, e-learning, KNUST. If you go to Pharm, you'll be able to have access to yesterday's lecture if you want to also listen to it again, you know, to refresh your memory. So I think, once again, Dr. Bochi has done a very good job, yes. And I think we should give him thank you very much, Doc. So we'll take our snack break, and then, you know, we'll come back for the next.